Okay, John, thank you so much for getting us started. Good evening and welcome, everyone. My name is Dr. Tristan Amador. Please feel free to call me Tristan. I'm the BC MHA Program Director, and I'm so excited that you've all joined us this evening. I think it's going to be a wonderfully engaging session. I would like to introduce Dr. Basel Tarab. He's our moderator this evening. Basel is MHA faculty. He's an MHA alum as well, a physician, a bioethicist, works full time as the director of the patient experience at Winchester Hospital. So many, many roles. And we really have Basel to thank for the topic this evening and recruiting all of our expert panelists. So thank you so much, Basel.
Thank you. Thank you,
Wanted to
Dr.
thank
Amador.
Thank you. And wanted to thank quickly all of our panelists for being here. We appreciate you sharing your time and energy and expertise so much. And then finally, John Ahern, he's our Assistant Director of Grad Programs. He makes all of these logistics happen. So thank you, John. And Basil, I'll turn this over to you.
Yeah, thank you. Thank you, Dr. Amador. And thank you, John, for making this happen. And thank you to all of our panelists and audience for being here. I know it's 7 p.m. on a Monday, but we will make this time hopefully a great time for everyone. Um, I want to start by saying that good evening, everyone, and thank you for joining us tonight. Most of us, when we think about hospitals, people, or we start picturing clinical care, patients, providers, and the bedside moments that define our missions. However, hospitals also run on living ecosystems, more like a small city than a single building. It runs on infrastructures, safety systems, engineering, security, and cleanliness. And when those systems fail, clinical care also fails. Typically, people only see the clinical care and they do not see those unseen services and disciplines. And that's why we are here today or tonight. We are here to learn about these services from our expert panelists. So what I will do here, I'll keep it a little bit casual. So I will go around my screen. I will just call on the name and I will ask each of you to introduce your name, your department, and maybe say a few words on how you would best describe your own department, and then we can take it from there. Let me start by Carlos.
Had to be me.
Good evening.
My name is Carlos Tejeda. I'm the Director of Environmental Services and Laundry at Winchester Hospital. I've been in the industry for over 25 years. That tells my age a little bit. Um, and, you know, there is a saying that you don't have to be a doctor or a nurse to have passion for healthcare, right? And every single employee, myself, we all have passion and we all know that our role is to make sure that our patients go home safe, that they arrive sick and go home safe, as well as the visitors and staff and everybody who works in the hospital.
Thank you, Carlos. Maybe next I will go to Pete.
How you doing, everybody? My name is Peter Girard. I'm the Director of Facilities. So we have a team of about 13 people that oversee the hospital and our 24 offsites. So we have a lot on our plate. Luckily, I have a great team right now, and everybody's really passionate about their work, and we really strive to the same thing like Carlos was saying, to provide a great environment for our patients and staff, and just to make that experience as well as we can by all the jobs that we do.
Thank you, Pete. Ron?
Good evening, everybody, and thank you for having us being part of this important presentation you're doing today. My name is Ron Knight, and I am the Director of Public Safety, Workplace Safety, and Shuttles at Winchester Hospital. I've been working in healthcare for now 35 years. It started out as a part-time job, and I thought it was only going to be for the summertime. And 35 years I'm here, so been a very fulfilling role. It's great being part of a team that in some way or another contributes to good outcomes with patients. So glad to be here.
Thank you. Thank you, Ron. And last but not least, Richard.
Hi, everyone. I'm Rich Garino. I am adjunct faculty in the BC program, and I am a former COO of Mount Auburn Hospital. I spent about 42 years in the healthcare field. About 80% of that was in hospital buildings themselves. I came to really realize as my role expanded I started off in radiology, as my role expanded, I came to realize how important the jobs of the three other experts on this panel are to the hospital. A hospital is a building with a lot of medical equipment and a lot of really talented staff, but it's really not a hospital unless the engineering and the housekeeping and the security is done right.
Thank you, Richard. So maybe I will start with you, and as you are already on the spot. So each of these gentlemen lead a very interesting department. However, you as a chief operation officer, you would lead the three departments together, and they would all report to you. What would be one thing that you wish that clinical leaders knew about these departments?
That's a really good question, Basil. I worked with, I'll tell you, I worked with a chief of trauma surgery at one of the hospitals that I worked at, and he was really into, how sterility was maintained with humidity and temperature and cleaning and all of those things. And he actually took a tour with the different experts that we have here at that place, their counterparts at that particular hospital. And when he finished his tour of all of the underbelly of the hospital and all the mechanical systems and things like that, he came to a managers meeting and he said, everybody in this room should go to that, should go on that tour. Everybody in this room should see what goes on in the background, because it's really impressive when you see all of the things that happen in the background that we don't necessarily see as clinical people.
Yeah, no, thank you. And that's a very good point. You want people to see what they are doing. And there are examples in which we see those three departments all very visible. Like when, let's say there's like a big weather alert and there is a flooding or there is something that breaks, that when people see these departments. However, when things are going smoothly, they are more on the back end and they operate in a less visible way. So maybe we could maybe Pete or Carlos or Ron can give an example in which there was a crisis in the hospital and how these departments function together, what each department's role was. I mean, I could suggest like a weather emergency, but feel free to suggest any example that would be helpful for us to learn from.
I think we could probably all go with what was it, 2 years ago, Ron, that we had the freezing. It was 4 days of, I think 4 days of freezing below. It was below zero for that amount of time. And in that time period, we once it got to that third day, we had all that cold air coming into our air handlers, and it froze the coils that do the heating. So that cold air can actually freeze that hot water very quickly, and the coils burst. So we ended up having about 5 air handlers' coils burst and a sprinkler head that was too close, that was near the outside of the wall. It wasn't insulated properly. That blew, and we had flooding throughout the hospital. It was a major crisis, and me, Ron, Carlos, and all of our teams were fast in action, and we got all the water stopped from flooding throughout the hospital, and the cleanup went really quick. I don't know if you guys want to add a little bit to that.
Sure. We had to use all of our equipment, right, from facilities. And what's more important is knowing that we have our partners from security trying to run equipment, floor care equipment, pick up the water, and they were right next to us. So it was something to see. I remember also we had to move the patients, right? Remember, we had to evacuate C3. And it was everyone in the hospital, not just environmental. Everyone was working together, just trying to get those making sure those patients were safe, and to make sure there was no more damage to the rest of the building.
Yeah, and these.
I'm sorry. Go ahead. It's interesting when we have events like this, and Peter Carlos and myself have been through quite a few of them together. And at the end of the day, it doesn't matter like what your discipline is. We all just hands in and we're all working together to get the right thing done, which is to continue providing care for our patients. You might see Peter wiping up a floor or mopping a floor. You'll see me doing that. And every time we have a situation, and even like this weekend, we had a situation with a power issue, we all come together and we do what we have to do to make sure it's safe for our patients, for them to continue to get care.
Yeah. So that's a good example, and I want to stress that these incidents happen in every hospital, and all the hospitals usually have their procedures to work through that. But again, those are the events. This example is a very visible one, but there's a lot of other examples that might not be as visible. But Ron, I'm gonna piggyback on your comment here, and I wonder if you could speak about the leadership behavior that a leader should have in these situations to prevent the situation from turning into chaos in these situations and turn it really into an organized mission to fix the issue.
So, again, with these type of situations, we have a lot of leaders, and it's just not here, it's throughout healthcare, that step up and do the right job. We work together, we guide each other, we feed off each other. So if Peter sees what I'm doing, he doesn't think it's being done right and can be done better. He's not afraid to speak up. And that's a sign, of a good, true leader. And even our senior leadership, they know they have the right people fulfilling the roles. So they let us do what we need to do to make things safe again. And again, that's a good sign of true leadership, because anybody can come in and try to take over an event. Sometimes they're going to do a good job. Other times they're not going to do a good job. But the basics of incident command is you have an incident commander, and then you have 3 to 4 other steps in between that, and you let those people do the job. You put them in that position because you know they can do the job, so let them do the job. And that's a sign of a good leader.
Thank you for sharing that. And Pete, this is a very good example, but it's an example about something that urgently happened. Would you be willing to share an example about something that may be in a less hectic atmosphere, something that is a planned project between the 2 or 3 departments among you, and just describe this department? What kind of work did it need to take? And then maybe after that, we could go to Rich and ask him, as a COO, how did he favor certain projects over others?
Okay, so let's just go with our most recent project. We renovated one of our ORs and made it a hybrid OR room so they could do any kind of surgery in there. And during that time, we used to have separately a holding area for the patients before they went into the ORs, PACU, post-acute care, and pre-op. So we redesigned a whole area so that was all enclosed into one. So it was a project that we had to do over, I think it was about 6 months. And every single one of those leaders here, Carlos and Ron, we all had to work together because we all had jobs to be able to keep the hospital functioning during this time. So we did this while we didn't lose any patient care abilities during this time. And we all came together to do this. So for example, being able to, we're working on the project, and Carlos would come in and make sure that, if we're doing night work, Carlos would come in and make sure that it's clean for the next morning, so we're ready to go with the next OR patients. Ron's security team, they were always there to make sure that the access control of the area was taken care of. Every single project that we do together, we work together. And we're lucky to have a really good team. Our leadership, we all come together and we listen to each other, and nobody takes the role of, that they're higher up than you, and they all listen, and we all get to share our experience and be able to share our expertise as well.
I agree, Peter. I think most important here, right, is patient safety, and, what you guys do, security, obviously, and, what we call terminal clean is a patient in an area will not go until that area is what we call as terminal clean, is disinfected properly, and so that a patient can be safe in that spot, in that area, right? That includes whether it's in PACU or in an OR, any area under construction, right? It's all about patient safety.
Thank you. Ron, do you have any comments about this project? Were you part of it?
Yeah, and there's a lot of behind the scenes things that people don't take into consideration sometimes. Like, every night after the work is done for the day, we had to have people go through the construction sites to make sure that the place is safe. So we're taking covers off of smoke detectors. We're looking for leaks. We're looking for all kinds of equipment that may be out that potentially could cause a risk if somebody gets in the area. We're continually doing risk assessments on our projects because, again, we want to maintain a level of safety for those who are not only part of the project, but that are abutting the project from above, below, beside it. The last thing we want is a pipe to break, or we want, a welding torch that may have not been shut off correctly that could cause a fire. So we do these inspections and we follow up with Peter's staff and with Carlos' staff and with all those involved, because there's other people involved too that are not on this call, people like infection prevention. They have a huge role in what we do. Again, we want to make sure the area is safe, and part of that is making sure there's no mold, there's no mildew. So infection prevention works with us hand in hand, making sure the air quality is kept at a certain level. Humidity levels have to be at a certain level. So there's a lot of work that goes into it behind the scenes that people may not see right away.
Yes. Thank you, Ron. And Rich, they brought the word safety into this, and we will be also talking about cost related to this. But if I may ask a question, how could you, as a COO, or what's the best approach for you, or the approach that you took into balancing between safety and cost for this kind of projects? For, again, those are projects that are important to maintain, but maybe not clinical, so people do not really put much focus on them.
Well, I think, every one of these projects will have a business plan related to it. Somebody has the idea that this was a good thing to do, and there's got to be a reason for that. So how does it impact the volume that we currently have? How does it impact future volume? How does the construction process impact volume at the time? What you want to try to do is you want to try to minimize the risk to both finance and patient safety. You want to minimize the financial losses during the construction project because you're going to have a room that's down, and you also want to make sure that patients are kept safe. Ron made some really great points, I think, about life safety. And a lot of hospitals, life safety kind of falls to everyone, and some hospitals have a life safety office. And with Peter's situation with engineering, as we're building things, I always like to have the engineer from the hospital look at how things are going together, because the architects and the engineers that design things aren't necessarily the people that are going to maintain them later on. And sometimes those things aren't put in a place in a way that you could actually easily get to them. So it involves a lot of people. First you want to make sure that you're doing the right thing and that you're building something that your patient population is going to actually utilize. And then you're going to try to minimize the impact to current patient volume, minimize the impact to current finances, but it's going to cost you money to do it, and you're going to have a room down, so you're going to lose some revenue for a short period of time. And then, as everyone has said on this call, you want to make sure that it's the safest environment you can. So you have architects from the outside that are helping you design. You have construction people that are going to help build it. You have your own internal security, life safety, engineering, and housekeeping staff involved. You also have the end users involved. The last thing you want to do is build a big, beautiful suite and they walk in there and go, this shouldn't be here, it should be over there. So you have your end users involved too, and that minimizes the rework and as built, as they call them in the industry, where it looks like this on the drawing, but that's not how it looks in real life. It's as built. So I think having all of those people involved, all of those different stakeholders involved, all listening to each other and all trying to work through the problems together, and all trying to keep the patient safe and keep the building safe, is how you get to the end product. And again, it's every case has an ROI. Sometimes those ROIs are negative, but you do it because it's the right thing for your patient population. Hopefully, you get enough positive ones that the negative ones don't really matter. But you will do projects that will not make money. They'll cost money, and but they're a service that the population needs. The community. I look at hospitals as, we're not just a care provider, we're a neighbor. We're part of the community. We're taking care of our community.
Yes, and that's a very good point. There's value to these projects, and value could be seen in other ways, not only just monetary. One thing, I want to also just, make sure that, I'm not persuading, just giving an image that there is no, like the work that these departments do are separate from clinical. In fact, actually, they impact the clinical work quite significantly. I was actually speaking with Carlos the other day, and he was he explained to me one example that I'm going to ask him to share with our audience, how his the speed that his staff clean the room might impact the hospital operations, both financially and from a throughput perspective. So, Carlos, if you would be generous enough to share that example.
Sure. That it's something that is priority for us. It's making sure patient throughput, right? It's from the moment a patient walks into an ED until it gets placed in a bed. And the role that we have is making sure from our end, just like everyone else, we have metrics, right? And we have industry standards. So we have to make sure, if the average, for example, is 30 minutes from the time a housekeeper gets into a room to the time it's ready for the patient. And then we have what is called total turnaround time. So we have to be within those metrics to ensure that we are doing our part. First of all, is for patient satisfaction. Secondly, is the sooner we get the patient from the ED into a bed in an inpatient area, that patient will start getting better, right? So it's all about working as a team. So we have a role. In our role, it's just as important as somebody, as a nurse who is at the bedside, or as a physician. Um, our role is to make sure, first of all, is that when that patient gets into that bed, that it was disinfected properly. It's, I think there's a misconception in environmental services for a hospital and healthcare in general. We do not clean, we disinfect. That means that it's total different. You clean at home, we disinfect in the hospital. We use different techniques. We know how to apply all the different techniques to different areas of the hospital. So again, it's all about working within those metrics, right? Getting that patient into a bed as soon as possible.
Nice. Thank you. And this is truly reflects keeping the patient and their safety at the center of your work. And but I mean, Carlos, how do you convey this message to your staff, and how do you maintain that the patient safety is actually at the front and center for them while doing their work?
Sure. So it starts from the moment we hire somebody. They have to go to a 3 weeks training. They need to learn all the processes of even knowing, for example, what is C. diff, right? What is MRSA, and how do we clean and disinfect when somebody has on those type of precautions. So we will not allow somebody to clean a room on their own until they pass a competency assessment. And yeah, and then we also have simple tools. What we have, for example, for QA perspective, black light inspections. So it's for example, we go into a room and dab, a few spots, high touch points, for example, and after the housekeeper cleans, we go back and inspect, and they miss certain areas, with the blue light, we just go in and try to show them. And so it's all about training, and for them to understand how important is the role of a housekeeper or environmental services professional, because I believe that's what they are. They're not housekeepers. They don't go around with mops, in a bucket. They use, I think, disposable masks, for example. We use disposable wipes. All, again, is from the patient safety perspective.
I see. Thank you. So maybe, Pete, if you could speak a little bit about how do you show your staff that their work is valuable. It is maybe not very seen, but it is really impactful.
Basically, I think the biggest thing that we do for our staff is we involve them in everything that's going on. We like to tell them what projects are going on. They're always, no matter what, even if we have outside contractors doing a project, my team is involved in that project. Making sure that, you know, once the project is finished as well, that that they're involved in the recognition, and we always try to make sure that we point out all the good things that different team members have done during while they're doing these things, so that they feel that sense of accomplishment just like we do. After finishing a big project like we just did with the OR area, I mean, I'm proud of what we did, and I think it came out amazing. And you can tell it was kind of nice. I had all the OR staff before they actually got to see the project finish. I was in there one night, and the night people didn't really get to see what happens during the day. So I brought them into the new OR, and they were amazed, and they were excited about what's going forth. So doing things like that and making sure that your team is up there with you so that they all know exactly what they did.
Thank you. So Ron, I'm gonna move to you now, and I actually have a question about a common debate that I usually hear in hospitals. Should security be visible or not in the hospital? Being a place of healing and, you know, security being security. Where do you stand on this debate?
So I feel they should be visible. You know, it's not like the old days where you would start a person for security and that night give them a flashlight and say, hey, you're hired. We invest a lot of time in our offices now. We do from onset anywhere from 4 to 6 weeks of training, everything from customer service skills to de-escalation skills, how to respond to a fire, how to respond to a hazardous material spill, and everything else in between. Often security is the first person that somebody will encounter when they come in the building. So it's very important that we train our staff to be very fluent in a lot of different things. Officers from security will respond to fire alarms. They'll be the first one on scene most of the time out in a parking lot when you have a patient that's unresponsive. They'll be the first ones who are initiating CPR out there. So security definitely has a huge role. More and more these days, where the world is not a better place, it does make people feel safe to know that somebody is keeping an eye on what's coming in the building and that somebody is available to respond to an emergency if needed. We take pride in our staff. It goes from when we hire the person. You know, as far as I'm concerned, if we determine that we're going to hire you, we're making an investment with you. So we don't want to just try, you know, a 1 week training or this, and if it doesn't work, we'll cut you loose. We actually spend a lot of investment on our staff because we want them to succeed. At the end of the day, if my staff succeed, I'm going to succeed. It's going to make the hospital succeed. And day after day, we get a lot of compliments on our staff because of that philosophy. People are very appreciative to seeing the security staff out there.
Thank you. So that makes me think, or a question comes to my mind, Ron. How difficult it is or how easy it is to hire for your department to find security or well-trained security staff that you would trust to be a part of your team?
So these days, it's a little bit harder with a lot of people retiring from law enforcement and getting out of public service. A lot of people are at that age where they've done the 20 to 25 years. They're feeding off my officers. But what's interesting is a lot of police departments now will only hire people that have hospital backgrounds. It's because of the training we do with our officers, the behavioral health. When you have a security officer who may sit with a psych patient for 8 to 12 or 16 hours, they show that that person has a lot of tolerance. And everybody knows when you're working with the public and the police are working with people, you need to be able to have a lot of tolerance. And this really gives them the tools for having a successful career in law enforcement. So do I struggle at times? Yes. But I'm also very selective in who we're going to put in. We have a hiring process. I have a manager who hires. He then, once he feels good about somebody, he works with our human resources department. He works with me, and we dig deeper into this person to see if they're truly going to be a fit. And if we feel they're going to be a fit, that's when we've committed to this person that we're going to make them succeed here at Winchester.
I see. Thank you, Ron. Carlos, would you please comment on this? How difficult or easy to find staff for environmental services in current atmosphere?
It has been more difficult after the pandemic, with now we get more folks that English is second language. Some folks can't speak English at all. And Rich will know about this. It's everything ties back also, not just patient safety, but also reimbursement for the hospital, where, as you know very well, patient satisfaction it's the driver for revenue. And when you have staff that cannot engage with a patient, in some cultures, whether it's in Latin America or Africa, housekeepers or environmental service employees, professionals are supposed to be in the shadows, right? They're not supposed to be seen. So it's a big commitment to try, and it takes a lot of time to train folks to say, no, you need to say hello, and you need to be upfront, and you need to let them know what you're doing. When in some country you say, nope, it's a housekeeper, just it goes in the background, right? So, and that's why it's extremely difficult at this point.
Yes, thank you. Thank you, Carlos. So Pete, can you also speak about that and about your department, whether is it difficult or easy to find qualified people in your area? And I also have a question, like additional general question for you. Like, what kind of staff do you have? Like, do you have like carpenters? Do you have plumbers? Do you have HVAC people? Is it like all in one, handymen? What is it?
So we do have a combination of all those things. So we have an HVAC technician. We have an electrician on staff. We no longer have a plumber because most of the time, anything that's not general plumbing, it's going to be hired out anyways. But a lot of our guys are they're able to do it all, and we have people that are previously painters, roofers, all kinds of different things. It's definitely difficult, especially because we're in the Boston area, and like an HVAC technician that wants to go to work for a company is going to make a lot more money, and we just can't compete with that kind of salary. So we tend to find the people that are looking for more of a stable life, because most of our tradesmen like that, the electricians and HVAC guys, they are looking that they would rather work a 7 to 3 shift than be on call be working 12, 15-hour days every day and driving all over the place. So there's good and bad things to working at the hospital. But I think that once they come in and we train them and they understand the atmosphere, we've been able to really keep some good staff members. And we've had some longtime people that have stayed with the hospital for, 25 years. So it's definitely difficult as time goes on, but we always seem to find the right person, and our team's really come together lately.
Great. And Pete, do you create like a pipeline for employees in your discipline? Is that something applicable, or is it more applicable in other disciplines? Like for example, this is a program for healthcare administration students, and who will be healthcare leaders. And pipeline is a huge topic there. You work on it from the grassroots and you grow them. Can we do that, or can you do that in your area?
Absolutely. We've brought some people on that have had different skills, and they've trained with other people, and they've learned all these skills. And we also reach out to people like the trade school and get younger people in there. But these are people you can groom, and it's a great place to do that because they have the opportunity to do like the regular maintenance stuff as well as work with subcontractors that come in. That's when they really learn their trade better, and that's when they really get the experience. So I think that we've definitely been able to grow people throughout the hospital. and we've created some great employees this way, great team members.
Thank you, Pete. So, Rich, hearing all this department descriptions and all of that, could you speak a little bit about when do you depend on departments like this internally versus contracting with external companies from a COO perspective? What are the factors that you consider and how do you weigh it in?
Yeah. Well, the getting the job done is the most important part. And then how much is it going to cost you to get the job done? Hospitals typically don't pay very well when it comes to these disciplines. And I'll be honest with you, I fought that battle many times over the course of my career as a director and as a vice president and as a COO. It can be really difficult. But I think, as you look at one, you want to go with what the experts feel is the most important thing. We want to get the job done. How do we get the job done, and how do we do that in the most efficient manner, both labor-wise and monetary-wise? I know that I've worked at hospitals where I've had 20% of my housekeeping staff was contracted out because we just couldn't get enough people in to do the work that needed to be done. The same thing with, I would always defer to my engineering people if they said, we needed to bring in an outside person to do X. And I think most of the hospitals that I worked at, I agree with Pete that most of the times we outsourced plumbing because it's just, so there were some things that, a one plumber can't do. You need 2 or 3 people on some of these bigger jobs. So I think, it's a balancing act. You want to look at, what do you need to get done? What is the bare minimum of resources that you need to do it? And then if you need to bring in people from outside, you need to bring in people from outside. And that's going to cost you more. But those are the things you have to do. I remember fighting for housekeeping at I won't mention the hospital, one of the hospitals that I worked at back a while ago. And it was a 2-year battle. And we didn't get anywhere near where we wanted to be. Baristas at Starbucks were making more money than my housekeepers, and the housekeepers are doing a really important job. Now, I mean, baristas are doing an important job too, but they're not dealing with sick people. They're not dealing with dangerous infections. They're not dealing with personalities and things like that you can come across in a hospital. And they're certainly not doing the heavy labor that some of the housekeepers are doing. But we couldn't even get them enough money we couldn't even pay them on the same level as baristas. Now, some of that has changed, and Carlos can attest to any changes that have happened in the last couple of years because I haven't been that tuned into it. But I think that's where you want to look at. I think we talked about pipeline. We also should be talking about career laddering. How do we make it so that somebody can come in at an entry level job and they can move up in the organization? And even if they don't move up in my organization, do they move up in an organization somewhere else? And that elevation of those people as they get better jobs gets out on the street, and then suddenly everybody wants to come and work here because they know there's opportunities. So I think we need to have a pipeline, and we also need to have some kind of career laddering for as much as we can. I know they do it a lot in the clinical areas, but it's a little harder in some of the infrastructure areas. But I think we should work on that.
So I'm gonna dive a little bit further into the career ladder here, and maybe each of you can tell us how did they got into the role? What kind of skills or training did they need to have, and what does it make a good leader in your roles? And Rich, maybe you could start. How can somebody, a leader, become a COO? What are the skills that are needed?
I don't know. I kind of overshot the mark. I only wanted to be a director. I think it's I had some great opportunities. There's some great people to work with. I always tell my students, pay attention to the leaders around you, the ones that are successful and the ones that are not, because you can learn just as much from people that are not good leaders as you can learn just as much of what not to do as you can what to do, what you should do. And I think, being able to, step up and volunteer for things, being the being the go-to person, obviously doing good work and showing up. But, there's a lot of talk out on the internet about, and a lot of people read this about work your wage and, silent quitting and things like that. Nobody ever advanced their career by doing the minimum amount of work possible. So you got to get out there, you got to expose yourself, you got to talk to your boss about, what other opportunities can you get involved in? how do you be a good citizen in the department so that way other opportunities will open up to you. And I think that's where you start trying to grow your career.
Thank you, Rich. Ron, can you tell us how can you be a director of security?
A lot of what Rich says is exactly what I had to do. When I got started this 30-something years ago, security wasn't looked at as being, really part of the team. I'm sure housekeeping and engineering probably was the same way. But you get yourself involved. You be available for everything. I make sure that security is represented at everything we do in the hospital. Just like we make sure that Carlos is brought into it, or emergency management, or engineering. And over the years, we've been able to show what we can bring to the table. And it's not about what I bring to the table. I have a great team that makes me look good. And if my team makes me look good, then I get, then I look good for the organization, and maybe they'll think of me for something in the future. But at the end of the day, it's all about acting human, being a people person, engaging your staff, engaging your customers, because I'm a service provider, and I have internal customers, which is, it could be the nurse in the emergency department, it could be a nurse upstairs on one of the floors, or a lab tech. And I have external customers, like the people who come in from the outside. And then I have my I call them my employees, but it's like the people who work for the store, that my staff, my team. I gotta make sure their needs are taken care of as well. One thing I'm always very cognizant of is people have a life outside of work. I make sure my staff, if they have a kid's ball game, or if they have something they need to be there, very important, we find a way to get them there. I've had people come to me and say, "Hey, this is my son's first Christmas and I can't work Christmas." And I've gone in and worked for them. And the reason why I've done it, because I had it done for me. And at the end of the day, that's what your staff remember. Not only you being a leader, you're setting an example, and you're also, what would have been a lousy day for somebody missing their kid's Christmas, now they're there. And chances are, if they miss their kid's Christmas, they're probably going to get some pushing from their spouse to, start looking for a new job, that you don't have to work holidays and stuff like that. And healthcare is unfortunately, it's a 365, 24, job. And we don't do it to get rich. At least now you don't get rich in it. We do it because we all have a passion of doing the right thing and providing great care for patients. And we're part of that team. I might not be putting the Band-Aid on a patient, but my role and my team's role and Carlos's team's role and Peter's, the food service people, we all are part of that, solution for that person to get better.
Thank you, Ron. And those are all great leadership skills, in addition to the technical skills that you have. Thank you for sharing that with us. Pete, can you speak a little bit about the technical skills that somebody needs to obtain before being a director in your role?
Yep. So
again, I'm not trying to replace you or replace
No,
anybody here.
I get it. I love Ron's answers on a lot of levels, that you got to be that leader for him. But to get to like the position that I was at, I actually wasn't ever planning on working in healthcare. And my dad went for this interview and he found out that it wasn't the right job for him. It was at a long-term care facility. And he suggested that I go talk to him. And I ended up getting the job. And then I worked my way up. I used to be a carpenter. I used to I had a business with somebody that we remodel basements and bathrooms. You do need some trade skills. You have to understand how the building's put together. And the more you can learn, the better you're going to be at that. But a lot of my guys that have these skills, if they really wanted to, I'm always willing to help them go that extra step and to get the training that they need. Once I ended up getting into healthcare, I ended up going back to school, finishing and everything up. I got my master's in project management. And all these skills just help me. Everything that I do help me learn, how to be a leader. And it's about being a leader and understanding the technical side of a building. So it can definitely be learned by anybody. You just have to, like Ron said, you have to go the extra mile, and you have to put in the time and learn the right things. And I think most people could do that if they put their mind to it.
Thank you, Pete. Carlos, what technical skills does a leader in environmental services need to have?
I don't know what much I can add from what Ron and Peter said. I guess most important in my role is understanding that what we do, what my team does, what I do, can save people's lives. Basically, that's what it is. If we boil it down to, it's we prevent infections. We are the first line of defense to anybody getting sick in the hospital, right? So if you take that to heart and you understand it, it's like Ron mentioned, passion. That is your passion. You know what your role is. Your role is to protect staff, visitors, and patients, and then you want to transfer the same passion and understanding to your staff. Just like Peter, I started too in subacute care. When I was 18 years old, I was a housekeeper. I hated housekeeping. I never thought I was going to do it. I'm like, oh my God. I went from engineering perspective. And then I end up again in my environmental services. And throughout my career, I learned that it's more important is, again, knowing what our role is, prevent infections and save people's lives, literally, and have an understanding of your team. Like Ron mentioned his team, and I'm very proud to work with both of these gentlemen, and obviously with you. Everyone knows what the role is, and this I think this is why we are very successful in what we're doing. It's just knowing,
Thank you.
right, and what it takes.
Thank you. So I have a few questions for you, but I want to open it up. If anyone from the audience has a question, we could probably take that. Otherwise, I will start asking questions. I'm not sure I can see it here. Ron, did you want to add something? Oh, I see your hand is up. All right. Well, I have a question actually, which is about technology. Can you speak or give an example? Well, we all know that technology is very important in every role, and it's really in every department. It really helps us move our work forward. Um, can each of you maybe give an example about certain technology that they have in their area, and how is that helpful for their work? Maybe I could start with Carlos.
Sure. I think I'll ask this question to Rich. It's not a response, it's just a question. So UV disinfection, there's nothing more important than obviously a person going in and with the all elbow grease, right? And you clean perfectly. But then also we have technology of UV light or UV robots that go into an OR or in a room. And after a housekeeper cleans and disinfect that room, we also put a robot in there with UV light and sort of making sure there's nothing left behind. So again, that goes from a patient safety perspective. However, that technology is expensive.
I see.
Somebody like Rich would have to say, okay, can we afford $50,000, $100,000 in this thing for patient safety, but you guys doing a great job already, just cleaning and disinfecting without this technology.
Mhm. So this kind to reassure that the work is happening. I also remember you mentioning to me a new technology about cleaning, like devices that clean bathrooms in a
Yes.
more expedited way. Can you speak a little bit about that? I think that's helpful for people to, like, that's a good example, I think.
Well, it's sort of similar, but I guess what's the latest technology that we're using actually as a system, with the rover, right? So just one example, we use this platform. Uh, all housekeepers now carry an iPhone. You know, imagine 10 years ago, 15 years ago, it was just a mop and bucket. Now they're carrying an iPhone where they can actually put the phone into an area where it says that area has been cleaned. Also, they receive, if there is a request for a bed cleaning for a discharge, they will tap into the phone and get all that information immediately.
I
They
see.
will
I see.
know, yeah, they will know what that room is like, if it's just a standard clean, or if it has any type of precaution,
I
right?
see.
And so right now, that's the most important technology we're using, as well as, what changes the mops, flat mops.
Yes.
I think Rich, conversation before too, when we had to go from, he had to do it from reusable mops to disposable. You know what? It's very expensive, but it's again for patient safety, right? And
Mhm.
all these things ties back to
And
expenses.
and it's very interesting that you say this because for somebody who is like not necessarily from this department, when they walk they see the environmental services staff with a phone and a mop, but they don't know that this disposable versus non-disposable actually is makes a huge difference for their own safety when they clean, but also for the safety of the patients and the quality of the cleaning that or disinfecting that they do. So thank you for sharing that example. Uh, Ron and Pete, are there any examples of technology that you could share that your departments or or your disciplines, not necessarily in your area and in this hospital that you work in, like technology that you use and you think it's helpful?
I think technology is scary. I'm a geek when it comes to technology, and I love my toys. Uh,
Okay.
and we have some of the most advanced, like video monitoring equipment and other stuff like that. But the technology that's coming down using AI these days, it
Hmm.
scares me. Some of the stuff I evaluate now is just by the way the person's walking, they're able to tell the probability of that person having a weapon on them. We use tags to track babies throughout the hospital now. Before it used to be just on the floor. Now we have a LoJack system that will not only track the babies coming anywhere in the hospital, but it'll follow them going out into the garage. Or, for some reason, if that baby had the tag still on and went to another BILH site, it would track them there. So there's a lot of like technology things I think that is really, it's great to use on a daily thing for investigations and stuff like that. But I look forward to what's coming next. The software I'm evaluating now, if I'm able to come up with the funding, and there's funding out there through Homeland Security grants and stuff like that. If we have somebody that's suspected having a weapon, it will not only notify my offices, it will notify the local police department. And it will also give us a snapshot of who the person is, sends it to the office's radios. It's a lot of slick stuff out there. And, again,
I,
being a nerd with technology, I look forward to it, but it scares me on the other side too.
I just want to say if the head of security is scared, I'm not sure how we all should feel about it, but
You know what? The technology, it's just like when you're going into an airport these days.
yeah,
Hospitals have to keep themselves safe. And as soon as you
absolutely.
walk in an airport these days, a lot of these airports are using facial recognition, and they know all about you within seconds just by doing that.
Absolutely.
Yeah.
Pete, can you speak about the role of technology in your discipline?
Yeah, absolutely. So we are lucky to have built-in automation systems, BASs, and it's amazing what they can do now. I can, with a click of a mouse, go into any room, check the temperature. I can change their temperature. In the ORs, we're able to see there's pressure monitors that tell you whether it's positive or negative. We can tell when the doors open. So basically, we're supposed to have minimum of 20 air exchanges in an operating room, and we usually have 25 because of the different cases that we do. It'll tell us what these readings are at all times. So same thing, we ensure that our patients are safe by following the standards that are met out there. We have a million standards that we have to go by. But every year that it gets better. We just spent another $100,000 on new equipment that we're going to be implementing, and it's just going to make it easier to operate all of our equipment. We can see if anything breaks. We can fix a lot of stuff. I can go into my computer from home and be able to reset an air handler that went down. It's amazing what the technology is nowadays with building automation.
Thank you, Pete. Tristan, I think you had a question or received a question.
I do, but I would love to invite Janine. Janine typed a question into the chat, and maybe we can take hers first. Hers is about aging facilities and how that impacts each of your areas. I think it's a great question.
Rich, would you mind
I would.
answering this
I don't
question
mind
first?
starting off. Yeah, I don't mind starting off on that. I know that others will add. Having followed two previous COOs who were afraid to spend a nickel on the building, I've come into a lot of places that had a lot of deferred maintenance, and surmounting that is a difficult task because it's usually millions of dollars. It's not the hundreds of thousands. It's usually millions of dollars, and it's millions of dollars in things that nobody sees. And it's very hard to get donors to put their name on an air handler. You know, they'd rather put their name on an MRI suite or a CT scanner or a new OR. It's really hard to get donations and philanthropy for infrastructure projects. So you really have to approach these things from a logistical perspective of what's your highest priority. Like where's the biggest safety concern? What needs to be done first? And you work a list. It took us at one of the hospitals that I worked at. It took us almost a year working with outside engineering companies just to get the list together on all of the things of prioritization of how we would repair those. And then over the course of the following, it was about 3 or 4 years. I think we spent about $15 million upgrading. But you have to have that priority list first. You have to kind of really figure out what needs to be fixed right away, and what needs to be, what can be put off for another few months, and then you have to have a good capital plan. Capital planning is a big deal in hospitals, and a lot of times infrastructure areas get left out. So I've gone through that experience in 2 different hospitals. It is not easy. It takes a lot of time. It takes a lot of planning, and it takes a lot of convincing people that this is where the money should be spent.
Thank you, Rich. Carlos, Pete, Ron, do you have any addition or can you add to this question or to answering this question?
Yeah, definitely like what Rich was saying too. And these are the things that don't have an ROI.
Right.
Things like that we're in, the oldest part of the country pretty much, where people first settled and everything. And all of our bills, like my hospital is, it's 100 years old, over 100 years old, right, guys? And as you know, you're at Mount Auburn. They're older hospitals.
That was even older.
Yeah, exactly.
but it's Massachusetts, right? Most of the hospitals are very old. Yeah.
Yeah. And even things like that people don't consider, just like the outside infrastructure, the brick, this stuff has been around so long. People don't want it. Costs, like Rich was saying, millions of dollars to repair what goes behind the brick. There's a vapor barrier that's supposed to be behind there. These deteriorate over time, but to fix these things, you have to take the brick building apart. I mean, it's just amazing what you get into, and how much it costs. And that deferred maintenance that most people do is because they can't see, they don't want to spend the money until it affects them directly. So once we start getting leaks in the building, then they'll fix it. Once they lose air conditioning in the OR areas and we lose cases for half a day and they realize the money they're losing, they know that they have to invest money in that new chiller. So it's working together. It's working with your C-suite and trying to explain how important this stuff is to try to be able to get this money spent.
Absolutely. There is a huge hidden expense to not fixing things correctly or in a timely manner, and people usually don't think of that. So I'm just going to be mindful of time. It's 8:01 right now, so I wish we had more time to speak. But is there any last comment that any of you would like to give? Maybe an advice for our healthcare administration students and clinical audience on how to work with you guys. What would you wish that clinical people or also administrators knew about your departments? Just a last minute, and then we can conclude. Last comment, and then we can conclude.
I would just say if you're looking to be a healthcare leader with a clinical, discipline, remember that it takes a full team to really get you to be successful clinically, and those people are the dietary folks, the housekeeping folks. I'm sorry, the infection prevention folks. Sorry, Carlos. The engineering folks, the security folks, the patient transporters. These are all people who have truly important roles within the organization. And as Rich said too, you have to compete for dollars. Well, healthcare dollars these days are very competitive. There's not as much as it used to be. The margins from the payers is a lot less. Margins from the federal government is less. So every penny that comes into the organization is something that there's going to be other leaders that are going to fight for, just like you are. And at times, you're just going to have to work together. You're going to have to determine what the most pressing need is. And you might not get that CAT scan machine this year because Peter needs to fix the brick outside. And just have an open mind for that.
Yeah, thank you. Well, I think you said it in a very good way, Ron. I strongly believe that clinical excellence cannot happen without true operational excellence. So thank you all for being here tonight and sharing your wisdom. And I want to thank Dr. Amador again and John, of course, and the whole Boston College Healthcare Administration program and community for giving us the opportunity to discuss these important things. I wish you all a great night, and thank you all for being here.
Thank you. Have a good night.
Thanks for having us, guys.
Thank you very
Thank you.
much.